And Shruti, over to you.
Good evening. Welcome to Project Step 1 webinar. This is Shruti Bharadwaj. A small introduction. Project Step 1 is a volunteer-driven, non-profit collective of individuals from the startup community. Over 6,000 volunteer doctors and 500 volunteer counselors from across India have also joined the volunteer force to fight COVID-19 crisis. This webinar is all about mental health chronicles from family practice. Mental health is how people think, feel, and behave. It can affect daily living, relationships, and physical health. I welcome Dr. Ramkrishna Prasad, founder and director, PCMH Restore Health, Vice President, AFPI Karnataka, to the session. Thank you for being here, sir. Over to you.
Thank you, Shruti. It's really a pleasure, and this is a very important area that we need to talk more about. It's my immense pleasure to introduce our panel here. Our panel is very unique. Our panel is unique because it brings decades of experience. We have Dr. B.C. Rao, who's been in practice and who's been a leader and role model in family medicine for over 5 decades. We also have Dr. Ashujit Kaur, who is a family physician, palliative care physician, and community medicine professor, and who is one of the co-founders of Aveksha, a home-based primary care service, along with Dr. Prathamesh Sawant. Dr. Prathamesh is unique because he's a practicing clinical pharmacist who along with Dr. Ashujit, co-founded Aveksha. And as we will see in the session, there are a number of insights which clinical pharmacists and knowledge of pharmacotherapy can contribute to the care of patients. And we have Swati Bala. Swati Bala is a primary care psychology fellow at PCMH Restore Health and has been a tremendous asset to our team. She will share her insights as a practicing counseling psychologist. Dr. Rao, could I perhaps request you to just say a few words? Doc, I think you'll have to unmute yourself.
This webinar is unique in the sense it's the first time it is addressing issues of mental health that come up at the primary care level. Handling of health issues at the primary care level is somewhat different from what an institution-based psychiatrist looks at. And how this is unique and how well we are trained, or as it is how we are managing these issues, forms the basis of today's discussion. As you are aware, we have some case stories and some personal experiences to narrate, and I hope it's going to be useful to the lay, I won't say lay in the sense ignorant audience, lay well-informed audience, and also the doctors who are participating in this discussion. I'm not actually talking about 5 of us, but the others who are viewing this program. And it will give them an insight as to what primary care doctors should be doing or doing at present. Thank you, RK.
Thank you very much, Dr. Rao. Let me just outline some of the objectives of this session. Prajwal, could we go to the next slide, please? So the outline of the next hour is as follows. You know who we are. We are all practicing in family practice. Some of us are clinical pharmacists, some of us are counselors, and some of us are practicing family physicians. We will talk about firstly, what does mental health and mental illness mean from a community practice perspective, especially through the lens of a family physician. We'll spend some time on this first. After this, we will talk about, and throughout the session, we'll use snippets from our practice, personal experiences, patients we've seen, short stories, and things like that. We will talk about how commonly do we as practicing family physicians come across mental illness, and what is the spectrum of mental illness and mental health issues that we encounter in our practice? One of the most important elements or aspects of practice as a family physician is to have a high index of suspicion and also to be able to recognize mental illness. And sometimes this is a gray zone. So we will learn from our panel as to how they navigate the complexities and nuances of when to suspect, how to approach, what to do and what not to do when they consider mental illness or mental issues in someone they encounter. And lastly, we will reflect on how is the family physician approach to managing mental health issues in the community different perhaps from from the tertiary care psychiatrist's approach. So this is the lay of the session. Our goal is to at least have the last 10 to 15 minutes open for discussion with all of you as the audience. My request to you is please text us on the chat box, and Prajwal, myself, and Shruti, we will be monitoring the chat box. So whatever questions you ask, I will bring it up as the moderator towards the end of the session. So with these ground rules, let me start the session. I'll start with Dr. Ashujit. Dr. Dr. Ashujit, are you? Yes, right. Dr. Ashujit, I mean, as a practicing family physician in the community, and especially someone who visits people at their homes, what are ways in which mental health and mental health issues present themselves to you as a family physician? Could you kindly comment on that?
So yeah, since we visit the patient's home, we get a better perspective of a patient's socioeconomic status, his environment, and the family dynamics, which are all responsible actually for the mental health of a person. So patients present with in various ways. We are called for something, but the patient has actually some other complaints. Like we had a patient where we were called to visit and attend to his bed sore. And when we started talking to him, trying to build a rapport, asking details about his complaints, he started crying and he said, "I don't want to live. I just want to leave this world." And while he was crying and speaking to us, the son was pacing the corridor up and down and trying to stop us from asking him further questions which were not relevant to his bed sore. So there was something more to it than just his bed sores, right? Patients present to us by saying we are unable to sleep, fall asleep, or we keep waking up at night. I don't feel hungry, or I'm not interested in anything. I just don't want to talk to anyone. So there are various ways a person presents when we are at home. Yeah.
Thank you very much, Dr. Ashujit. No, exactly. This is one of the beauties of being a family physician. Many times it's never about the label that initiates the conversation. Dr. Rao, could you share with us some of the ways in which mental illness or just mental health issues present in practice, and your insights?
See, any patient who comes to a doctor is uncomfortable. In the sense, you can't expect a patient with a problem to see a doctor in a very relaxed mood. So, as it is, there is a certain amount of stress, anxiety inbuilt in the interview process. But then that is natural. Even physical health issues have this kind of a small mental health issue inbuilt into the presenting symptoms. This is natural. and all doctors have an idea about this. But then there are patients who come with slightly altered thought processes, which are unnatural. Now, as you know, mental health issues are basically related to this process of very altered mental processes, especially thought processes. And when these are awry, what happens is the presenting symptoms vary and they are abnormal from the point of view of the practicing doctor, primary care physician especially, because this kind of thought process alteration happens in a set which is influenced by very many factors, social, psychological anyway, the economic issues and the environmental issues. There are so many, and also the interplay amongst the family members all come into play when a patient presents with a symptom which is way beyond what it should be related to an illness. This happens very often in our practices. And we find, to give an example, somebody comes with a chest pain, a 20-year-old woman, otherwise fit. Why should she be having the chest pain? She may even describe classical symptoms of chest pain. She is a very well-informed person. And she might say, I got a chest pain. And she would give you a classical history of possible ischemic heart disease. But then you know that this cannot be. So why is this lady saying these things? So the suspicion that there is something behind this complaint immediately should come to your mind. I'll give you another example. A school-going girl is brought to you with complaints of truant behavior. She comes home, she weeps, she screams, she's uncomfortable, she vomits, she doesn't eat her food. And then this is going on for a while, and they're at a loss to find out what is the problem. So they brought this, they bring the young woman, maybe adolescent young woman, to see you. So her presenting complaint would be mild pain, abdomen, nausea, vomiting. On examination, history taking, you'll find out that this becomes magnified on Monday and Tuesday, and rest of the days she is managing, and weekends she is reasonably all right. So you know the problem is in school. So a high index of suspicion that there must be a serious mental issue behind the presenting symptom will help you to sort out the problem. Sorting out the problem is not easy, but it needs perseverance, patience, detailed history taking, sometimes in confidence with the patient being alone with you, and telling the patient that what she is going to tell you is going to be in strict confidence, and it will only be told to the relative concerned only what they should know. So that way, we'll be able to find quite a few of these mental health issues related to physical ailments. Having said that, I must also tell you that it is never a straightforward case. You cannot make a diagnosis of this, as psychiatrists tend to do, because they see a case which is already florid. And it is not so very difficult to diagnose those cases. But when these patients present to you with these myriad symptoms, to sort of, sieve those symptoms into known diagnosis is very difficult.
Thank you, Dr. Rao. Indeed, being a family physician, the primary art and expertise is in managing the undifferentiated patient, undifferentiated presentation, where you need to take into consideration all the different elements that you spoke about. Prathamesh, you're a clinical pharmacist. I recall you sharing a few stories where one of your patients was bedridden on a number of medications, and then also depressed. And you were sharing with our group how some of the medications could have contributed to this, and how managing polypharmacy was the solution. Could you share with us the case, the story? Thank you.
Yes, absolutely. So there was this 70-year-old person who asked for a home visit just for treating his diarrhea. And when we went to his home, he was completely bedbound. And we asked him, like, what exactly is going on with you? On noticing further things, like chatting with him, talking to his wife, talking to his daughter, we got to know so much in depth that he had completely given up just because he was not able to get up from the bed. And what had happened to him in an hospital made him lose the confidence of walking, doing his regular activities, and things like that. So, I mean, it's like a conveyor belt wherein a piece is kept and it just keeps moving along with it. And the particular doctor takes up the particular thing. Like this patient underwent CABG with stenting. He had 4 to 5 stents in his heart. And post which he also developed pneumonia staying in the hospital, which was treated accordingly with antibiotics. But then these antibiotics caused him to have diarrhea, and typically, a patient with cardiac failure is being treated with diuretics. And when these diuretics are given, patient is asked to restrict water intake to certain limits. And limiting that can further cause other issues, like he was not able to pass urine. So the case was moved to a urologist from a cardiologist. Now the urologist put a catheter so that he passes urine, and he was again restricted to water, and they wanted him to pass at least 2 liters in a day, and which was not possible. When we went saw him and did all, I mean, learned about all these things going on in his life, we told, okay, what are you basically doing with your medications? So he gave us 3 different medications which are basically used, not used appropriately or at the right dose, wherein he just needed one medicine 3 times a day, which really took care of him. Within the next 2 days, he was up and all right. The next visit, he asked us to get him off the catheter. We did so. And the third time, when we went in the same apartment complex to meet another patient, he and his wife were having a small walk, and we couldn't pace him to what pace he was walking at. So we had to run behind him and catch him and ask, like, how are you doing and all that. So it's really the small little changes that I mean that we have to think about. And most of the times what happens is explaining what exactly is wrong is completely a difficult task. But because medicine is all about the diagnosis, basically the single diagnosis when it comes to a hospital perspectives, it's very difficult to assess these sort of back end depression, anxiety, or similar things to it. So we try to prioritize meaningfulness to life rather than hitting a right diagnosis, putting strict sugar control or BP control, and then getting them off these conveyor belts so that they live happy.
That's a delightful point, and you bring up a very important point about person-centered care as opposed to disease-oriented care.
Absolutely.
And as we move in the conversation, we will spend some time talking about that. I want to pull in Swati Bala here. Swati, we know that each of us, or most people, or many people, live within the context of a family, and there are dynamics within the family which affect us, influence us in multiple ways. Can you comment and share some of your experiences in how family dynamics influence mental health, and how perhaps you have dealt with um, uh, dysfunctions in the family dynamic? Go ahead. Swati, you're not audible. No, not yet. Okay, while
She's getting it, yeah.
While Swati fixes her audio, Dr. Rao or Dr. Ashujit, would you like to comment on family dynamics?
Yeah, we live in a community. Family part forms a part of that community. Inevitably, the socio-psychological atmosphere in the family is of paramount importance in the clinical presentation of a case. This forms the basis of the interaction between the family physician, primary care physician, and the patient. The patient may come alone or he may come accompanied by another person. It's immaterial. But take it for granted that the presenting complaint, however trivial it may be, is always related to his relationship with his family, his environment, and of course, his relationship with you. Therefore, look at all these aspects. When he says, I've got a headache, don't jump to a conclusion that he's got some serious illness support. Find out, don't miss out on anything, but check on all these aspects before you come to a conclusion. That's why family medicine practice is so very interesting. You find out things which others cannot do just because they're not placed ideally to do this.
That's wonderful. Thank you for bringing that up. Dr. Rao, I'm going to ask you to share a snippet, perhaps, where because of your relationship, you were able to influence the family dynamic and the person's mental health subsequently.
I told you about this 12-year-old girl truant behavior some time ago. I found out that this kid, 12-year-old girl, has had some kind of an emotional relationship with another boy, with another 1 year senior to her. But then she was so scared that this will come into open. There was nothing happening between them. They were just close friends. But the scare and the fear of what's going to happen if the family comes to know, how will they behave, what are they going to happen. And she was missing her studies, she was not concentrating, and she was all the time on telephone. And that led to the mother getting concerned. Mother started cursing her, you're not behaving well, you're not studying. And the father comes home in the evening at 9 o'clock. He takes to also to criticize her, and once in a way even beaten her. So the girl was in a mess for very, very trivial reason, but for her it was a serious issue. It was easily sorted out because I talked to her and found out that she's not doing any crime, talked to the father and the mother, and they invited that boy and his friends also to the home, and all hunky-dory afterwards.
Great, wonderful. Many times we as doctors, we forget that just being the doctor is the medicine. And especially if the doctor does three things: listens actively to a person sitting in front of them, is non-judgmental, and expresses empathy. These are very powerful tools which make people feel better, which can uplift people's mood, increase a sense of hope and a desire to look forward. So these are family physicians can do. Swati, are you able to speak now? Okay, not audible still. Okay, not a problem. I will come back to you in a little bit. I want to move to a segment where a quick comment, because a quick comment from each of you. How commonly do you come across mental health issues in your practice? Is this something which is rare? Because many times I come across people, even interestingly, when this flyer went around, there were a few people who responded to me. They said, "Oh, this is so wonderful. We never knew you did mental health." Right? which to me, of course, I mean, they said it in an encouraging way, but it also demonstrated a certain imagination of what mental health is and how mental health is a specialist domain, or how mental health and physical health or whatever are two different dimensions of practice. From your perspective, how common is mental health? How common are mental health issues?
Pretty common. Pretty common. As I said earlier, behind every physical symptom which the patient presents with, there is a certain amount of mental stress-related issues. So, as I said, so you can't separate the two. But then, if you really want to assess that whether this patient has a serious mental issue, which is presenting as a physical symptom, I would say yes, quite frequently. That is why I said you have to have a high degree of suspicion that this is really mental health related issue, and very little that the physical complaint has to do with the patient presenting with that issue. So that one can gain by experience. One can also get it by, I would say, an intuition which you develop over a certain period of time. And then if you recognize that, you can help the patient out in more ways than one. Medication is the last thing that one should think of, because you get a mixture of symptoms. You can't say, just because he's saying I'm not able to sleep, you can't dump him as a person with depression. Ultimately, it may prove to be so. But when he is presenting to you with complaints of headache, you can't say because he is presenting with headache, that is the reason why he is not sleeping. So it could be that he is carrying a kind of a negative thought into his head, all the time worrying about it. And today, as I said earlier, stress is a major part which plays in our day-to-day lives. It is across the board. It's much more common in this lower socioeconomic group, not so common, but it is becoming increasingly common. As you are all aware that the ongoing COVID epidemic has destroyed the normal living pattern of most people. And the stress levels of some of us and some of our patients is at all-time high.
Thank you. Swati, if you're able to speak now, would you like to comment on some of these things from the perspective of a counseling psychologist?
Yes, so I'm sorry about the connectivity issue earlier. So yeah, so family is the primary contact for any person, right? So we are from a family, we belong to a group of people. So it's not just in the recognition of a mental illness, but also with the management, to some extent, the causation, the family is involved. For example, there is a couple who always have fight. The kid is gonna get affected, so family plays a really important role, and they're the first contact to recognize that there is a change of behavior or there's a change in a pattern. Usually, a person works. It could be sleep, it could be appetite. So my journey here with the physicians has been like really great. It has taught me and it has given a different perception towards it, because always I believe in a holistic approach. Like there's a dichotomy between physical health and mental health. If you actually look at it, they both go in each other. Like if something happens physically, it affects the emotion. If something happens emotionally, it affects the physical health. For example, no sleep or appetite problems, all these are physical alignments, but it could be because of the emotional issues. So it's important to address a person holistically. I think Prathamesh has said about the person-centered approach, where you see a person as a whole and address all the things. So there are a lot of examples from the practice along with the physicians. One such is, which I would like to say, is about a girl who was found with a behavior issue by the family. The family was really distressed, and the first point of contact was the physician, because they were the physician was the family doctor. So then they discussed about what has to be done, And then I got into place, and then we had a family meeting. We comforted the family, we gave them trust, we gave them assurance that it's going to be fine. Then I worked with the kid personally, and there was a dramatic change in it, what has happened. So this example, if you look into it, it was very easy for me to step in because there's already a relationship that was built with the family physician. So it was very easy for me, and the family trusted me, the kid trusted me. So the relationship or the process of healing went by smoothly. So if you look at any problem or any issue when it comes to a psychiatrist or a psychologist, the primary person who is involved would either be the family or the primary physician. So it's very important for a primary physician to address the mental health issues, to recognize that okay, there's something else other than the physical thing which has to be given notice of. So yeah, that's my view.
Thank you, Swati. Dr. Ashijit, uh, you're also a palliative care physician. And, a physician, especially a family physician, is incomplete if the family physician does not play a role when, a family member or one of our own patients is passing through the last phases of life. And we can all imagine this is a very distressing, stressful, anxiety provoking period, not just for the person who might be at the end of life, but also for the family. Can you share with us a couple of snippets from your practice where you help families navigate this transition or this phase?
Yeah. So actually, recently we had a patient where uh, he was diagnosed with cancer lung, and he was all by himself in Kolkata because his family was one daughter was residing in Bangalore and another residing in Dubai, and nobody was with this person, and he was all by himself when he was diagnosed with this illness. But he was not aware that he has cancer. He just knew that he has some problem with his lung, probably a pneumonia. And during the COVID time, with the complete lockdown, the family was not able to access to reach him, or he was not able to come down here. Ultimately, they were able to manage to bring him here in the month of May, towards the, between the lockdown period. But now the family is aware of the diagnosis. The patient was not at all aware. And they were scared that what if he comes to know that he has cancer and he is not going to be there for very long. And when I asked them that, does the patient know about his diagnosis? They said, no, we don't want him to know because it just might kill him before time. So I could see that anxiety and stress on the face of the patient's family. And usually what happens is the family is trying to be protective towards this, that the patient might fall very sick or might go away earlier than what is expected. But I always tell them that just putting yourself in that situation, if I was in that situation where I have an illness where I don't know what my illness is putting through a lot of stress to the person who has an illness. Knowing that I have something, even if it is not treatable, it's not curable, it does give some kind of a relief. And I said that I'm not going to disclose him all of a sudden. It will come at a slow pace in a manner which is acceptable to you and to the patient. So let me go step by step. And the first thing is the family needs to accept. Now the family has accepted the diagnosis, but is unable to accept that very soon they're going to lose this person from their life. So there's so much of stress and anxiety in the family, which was very evident. And once I spoke to the family the first time and made them understand the need for knowing that, accepting the diagnosis, and for the patient to understand that he is going to be comfortable at whatever stage he is, that we are not going to put him through pain. And when we started the medication for the patient, the next visit, the patient was so happy. And when I was leaving after the first visit, he said, "When are you coming again?" So these are some of the things, yeah. Like that, of course, we have lots and lots of snippets from our practice, our day-to-day practice, where as family physicians, we are not only looking at the patient, but the entire family, how important it is to the health, the mental health of the family, which plays a role on the health of the patient as well.
Great, Dr. Ashwajit. I'm very excited to share with you. So it's about 5:38. I think we can involve the audience now because there have been some wonderful comments and also a couple of questions. I'll just read a couple of comments. Dr. Swapna Bhaskar has reinforced a very important message, which both Swati and Dr. Rao made previously, which is being a family physician is in some ways almost a relationship which is that of a friend or a confidant of the patient and the family. And many times patients are more open with us and prefer counseling from us than a referral to a psychiatrist or a psychologist. I think that's a great point. See, mental health definitely has, mental illness has stigma. But I think I would underscore what Swati said. Sometimes, if the family physician can be a bridge whom the family trusts and with whom there is no stigma attached, and that trust is transferred to a mental health specialist, because sometimes as family physicians we do need the assistance of psychologists and psychiatrists. This makes people and people, families, patients feel a lot more secure and able to engage, and able to benefit. So thank you, Dr. Swapna. The second comment from Dr. Soumya Vivek is that she says it's a question. A quick assessment of mood, sleep, and food intake, even in a busy OPD, may give clues towards mental health issues. Dr. Rao, has this been your experience? Would you like to add?
Yeah, I more or less agree with her. It's true, because these are common day-to-day issue. Your sleep, your eating pattern. These, if you are not in the mood to eat, you can't sleep. There is something cooking there. So that these are very valid points. But then, as I keep saying, the presenting symptom of mental illness is a mixture of symptoms. They're not clear cut. You cannot categorize those symptoms into a known entity. You can't straight away say he's got this disorder. Even psychiatrists over the period of last 20-25 years have now found out many names, many categories of mental illnesses. The more you dig into these, more and more names come up. That is not true in family medical practice. We cannot say this patient has this disease, but we know that he has got something wrong with his thought processes. And his reaction to those abnormal thought processes need not necessarily be categorized into a known illness in primary care practice. This is my take-home message to all of you who are listening to us.
Great, Dr. Rao. There's one more question from Dr. Amrita Rajeshwari, which I'll request Swati to respond to. How do you tackle anger in adolescence?
Yeah, so adolescence is a very crucial period where there's both physical development and also emotional development. So there are a lot of components that's involved in why the person becomes angry. So that is the first thing we need to find. Is it related to phone, or is it related to friends? Is it related to academics, or is it related to family? So we need to identify what is the dynamic and what is the context of why they are getting anger. Then maybe have a conversation with them to understand what's happening. That's the best way to do, because in adolescence there are multiple other things comes first than family, like their self identity. There will be what to do next. There are a lot of things that's there, so which would again create them stress. So it's important to identify why they are getting angry, what is the reason behind it. So probably have a discussion with them and figure out how it is done. That would be my answer.
Great, thank you. Ashujit, would you like to add to that from your own experience?
Yeah. So I think I would just go by what Swati has told. And we do see a lot of adolescents also having issues where it is more of the family dynamics which are playing a role in the health of the adolescent, the mental health of an adolescent. So we need to look at what's happening in the family rather than just concentrating on the adolescent who has a problem.
Great. Dr. Rao, Dr. Rao had brought up sometime at the beginning of the session the importance of emphasizing confidentiality. And I think the other element is to be non-judgmental, and non-judgmental in listening to people. There's a third element I'd like to bring up. Sometimes we as physicians, this is called the writing reflex, RIGHTING. What happens is when someone comes to you and starts talking about a problem, we want to fix it. Because it's harder to kind of listen. So many times, it happens to me sometimes when I'm not having a good day. Someone comes and says, "Doctor, I have a headache." I immediately want to give him paracetamol and say, "Look, take this and you'll be fine." But sometimes I think it's important for us as physicians, especially family physicians, to check ourselves when we are being a little too eager in solving someone's problem, and step back and say, the real solution, the real therapy is listening, and just listening, attentively listening in a non-judgmental manner and expressing empathy. Um, Prathamesh, can you give us some examples of situations perhaps where you've used listening and empathy to help someone?
So, I mean, there are plenty of them, but I would like to bring up this one unique case wherein it was more about her and the stresses that she was going through in her life. Plus, she had to take care of her father at home, and basically, she had called us to answer her abscess, which was at the region region, and we had to go there, treat her for that. But then one fine day when we went to see her, we uh, we were just called by the security guard that something is wrong. Please do come with us. And when we went, rushed to their home, it was actually her father who was staying in the opposite home on the other side of the building, and he had a fall, which he couldn't get up for 1.5 hours. He was shouting out through the balcony to the neighbors, but no one responded. And this was totally during the COVID time, and the daughter started panicking. So we had to calm her down, bring her to senses that things do happen like this. Do not worry, and stabilize her father in one side. And later on the next visit, and so she was more stressed because whatever incident had happened in the past and things like that. So we thought, okay, let's get her labs and things done, which showed her to be a diabetic. Now, this diabetes was basically related to her stress rather than any other issues that were going on. Could be that, yeah, the other thing also could be she may also be a diabetic as such, but then the stress actually triggered it to such a way that it hit the HbA1cs of 13, 12 to 13. And when we got to know about this, we went, spent some time with her, explained her how things happen and how she can do it in a better way. So just small little things like that do make difference when we spend time with the patient, understand what their basic goals are, and help them cope and get to those needs and goals. So when they define their needs and goals, it's easier for a family physician to just be with them and take care of them in a holistic way.
Thank you, Prathamesh. um, um, one other element is sometimes there are mental health emergencies or urgencies that happen in practice. Can we talk very briefly about how a family physician can respond to a mental health urgency or emergency? Dr. Rao.
I have personal knowledge of associate handling one such issue recently. I think she would be better placed to explain what.
Sure, sure. Ashujit, over to you. Yeah.
Yeah. So we did have recently during this COVID lockdown period where we had an emergency kind where I was given a call one day and by somebody whom I'm well acquainted with. And this lady sounded so anxious and she said, my husband is behaving very weird over the last 1 week, hasn't been sleeping, has started hallucinating, he sees people and he talks irrelevant. And he's a I wouldn't he's about 49 years old. And she said, if you can come down and have a look at him. So when we went and met him, visited the family, he did look very dazed. He was trying to look very hard into my face as if he wanted to really understand as to what I'm saying. And his pupils were quite dilated, where he was trying to focus to looking at me and he kept saying that I'm fine. It's just that I haven't slept for the last 1 week, otherwise I'm all right. When I asked him, the wife did intervene by saying that you were hallucinating, you were seeing somebody, and he said, oh, that was just one thing where that person was actually shouting, I was not hallucinating. And then on further probing, I got to know that the family has been giving him medication covertly, adding into his tea or coffee or food over the last 10 to 15 years. And he is not aware that he has a mental health issue because he was never advised or counseled on that by a specialist. So while we spoke to the family and had about 2 to 3 visits in about 2 weeks' time, and I did not find any improvement, and it was getting worse, where he started getting aggressive, and the wife was scared that he might harm the child or harm, because he said that I'm going to go and beat up this person on the street. And that's where the wife got a little worried. And then we arranged seeing a psychiatrist, where he was moved to an institution and admitted under a psychiatrist. But we, as a family physician, played a bridge between the family and the psychiatrist, because the family trusted us because we had a relationship with them. And the patient also had trust. He was refusing to see a psychiatrist and go to the hospital. But when I reassured and said that we are going to be there and there's no harm which is going to come to you, he agreed. And today he has understood his problem, that there is a mental health issue. He's willing to take treatment. He is taking treatment and getting better. And the relationship between the husband and wife has also improved. So we did shift him to the hospital and got the help. So this was an emergency where we had to intervene. Yeah.
What a wonderful example. Thank you, Dr. Ashujit. So we have the last 5 minutes. I want to conclude. First of all, thank you, Dr. Rao, Dr. Ashujit, Dr. Prathamesh and Swati, and also thanks to the Project Step 1 team. I want to summarize a few unique facets, unique elements of the family physician approach to mental health. Number one, which we emphasized and which came out through some of the stories that all of you shared. The first was a family practice approach or a family physician approach uses an integrated or an undifferentiated holistic approach to understanding the patient's context and the interplay of family dynamics, social relationships, cultural background, and often economics in both what causes illness and the presentation and treatment to an illness. The second, which came out very strongly at almost every story, was the family practice approach builds on the existing trust that exists between the doctor, patient, and the family. Thirdly, it harnesses the power of the continuity relationship. When someone is there for a family, there is a certain level of power and trust which happens as a result of that. Family physicians taking care of mental health issues is associated with lower stigma. One of the things to keep in mind is sometimes the professional boundaries is more fluid and less defined. The principal therapeutic tools are active listening, a non-judgmental approach, and empathy. Family physicians who do not hesitate to visit patients' homes are particularly privileged in understanding many of these things. In family medicine, as Dr. Rao pointed out, labels and formal diagnoses are less important, and often contextual understanding is given greater importance. And finally, shared decision making and preservation of the autonomy of patients is at the heart of the approach. And one doesn't just interact with the patient, but also with the family. I think with this, I will conclude. Thank you all for joining this session. Shruti, you might have a few concluding remarks. Thank you. Thanks, and over to you.
Wow, that was a very informative and a much needed session for the present scenario. And the message that family physicians are the first friends that we can go to is so true. Thank you, doctors. This was really great. And Step One is honored to have you here, and we look forward for more such sessions. People
Thank you.
remember it's okay to talk about mental illness, and there is no shame in seeking for help. Stay tuned for more such interesting sessions and don't miss out tomorrow's webinar on coronavirus vaccines. Thank you, doctors, for your time, and we look forward for more. Thank you.
Thank you very
Thank you.
much.
Thank
Thank
you,
you.
Shruti.
Thank you.
Thank you all.